Yes, you can go ahead. You can make it full screen, Gauri.
Yeah, ma'am.
Yeah, big. Okay, good. Please go ahead.
Yeah, just a second. Yeah,
Yeah, better.
this is okay, ma'am.
Yes, Gauri, please go ahead.
Good evening, everyone. Today, my topic of discussion is a comparative pharmacology of local anesthetics and local anesthetic systemic toxicity. I'm Dr. Gauri Rajendran, an AORA fellow from Manipal Hospital, Yashwantpur, Bangalore, and my moderators are Dr. Hetal sir and Gaurav sir. So, what are local anesthetics? They are drugs that can block conduction of nerve fibers or nerve conduction reversibly. So, first, let's look into the history of local anesthetic. The first local anesthetic was cocaine, which was isolated from coca leaves by Albert Niemann in Germany in the 1860s. And Karl Koller introduced the cocaine as a local anesthetic for topical ocular anesthesia later. The first synthetic local anesthetic was the ester derivative procaine introduced by Alfred Einhorn in 1905. Now, coming to the chronology of the discovery of local anesthetic agents, we saw that in 1860 cocaine was introduced. After that, in 1905, procaine was first synthesized by Einhorn, and the first amide local anesthetic, lidocaine, was introduced in 1943. In 1963, bupivacaine was synthesized, and in 1997, ropivacaine was clinically introduced. Around 1998, levobupivacaine came into use. Coming to the chemistry of local anesthetics, they are weak bases and they are classified as tertiary amines. They have an aromatic group as well as a tertiary amine. And this aromatic group is lipophilic, whereas the tertiary amine is hydrophilic. And these two groups are joined together by an intermediate bond that can be an amide bond or an ester bond. So depending upon the bonds, we can classify local anesthetics into aminoamides and aminoesters. Aminoamides include lidocaine, prilocaine, mepivacaine, bupivacaine, and ropivacaine, whereas esters include procaine, chlorprocaine, tetracaine, benzocaine, and cocaine. Coming to the differences between an amide and an ester local anesthetic, amide local anesthetics have a low pKa and they exist in a diffusible base form at the body pH, whereas esters have a higher pKa and they remain in the ionic form. Amides are more lipophilic, they are more protein bound, they have a faster onset of action and they are more stable, and hence they are used more commonly than ester local anesthetics. Amides are less allergic, whereas esters are more allergic. Amides are metabolized by liver, whereas esters are metabolized by plasma pseudocholinesterase, and the metabolism is faster. Coming to the classification of local anesthetics based on duration and potency, they can be short duration, low potency drugs like procaine, chlorprocaine, or intermediate duration and potency like lidocaine, mepivacaine, prilocaine, tetracaine, or long duration and high potency like bupivacaine, levobupivacaine, ropivacaine, and etidocaine. Coming to the structure-activity relationship. So, modifying the chemical structure of local anesthetics can alter its pharmacological effects. Increasing the number of carbon atoms or the tertiary amine or the aromatic ring often results in differences in lipid solubility, potency, the rate of metabolism, and the duration of action. So here you can see that the tetracaine in the procaine there is a methyl group that is replaced in the procaine aromatic ring, and this makes the tetracaine. But tetracaine is highly lipid soluble and more long acting compared to procaine. Coming to drugs that are generally classified as pypic colloxylidides, we can see that they basically have a same chemical structure. So initially mepivacaine has a methyl group, this has a ethyl group, and in ropivacaine there is a N-methyl group. So depending upon the change in structure, the activity of the drug also varies. Coming to racemic mixtures or pure isomers. The pypic colloxylidide or local anesthetics like mepivacaine, bupivacaine, ropivacaine, and levobupivacaine are chiral drugs because their molecule presses an asymmetric carbon atom. Asymmetric carbons are those carbon atoms that are attached to three different groups over their three different sides. As such, these drugs have left, that is S or the right-handed configuration, and mepivacaine and bupivacaine are always usually available for clinical use as racemic mixtures, that is a 50:50 mixture of R and S isomer of the enantiomers. Coming to differences between a racemic mixture and a pure S isomer, The composition is equal mix of R and S isomer, whereas there is a pure S isomer in the pure isomer form. Potency of the racemic mixture is high, whereas single enantiomer is relatively low. Cardiotoxicity is higher with racemic mixtures. CNS toxicity is as well higher. Cost is cheaper. Examples are bupivacaine, mepivacaine, lidocaine, whereas single enantiomer is ropivacaine and levobupivacaine. Coming to the pKa or the dissociation constant. pKa or dissociation constant is the pH at which the local anesthetic is 50% ionized and 50% non-ionized. Local anesthetics are weak bases. The agents that have a pKa closer to the physiological pH have a more drug in non-ionized form which can diffuse through axonal membrane, and so the onset is rapid. That is why lignocaine with a pKa of 7.8 is fast acting than bupivacaine with a pKa of 8.1. So we can see that procaine have a higher pKa, whereas compared to bupivacaine, ropivacaine, lidocaine has a pKa almost close to the pH body physiological pH levels, more than mepivacaine. So local anesthetics always exist in a solution in a chemical equilibrium between a uncharged form and the charged form. So this is the Henderson-Hasselbalch equation. It suggests that the log of ionic to the unionic form is equal to pKa minus the physiological pH. So as the pH is closer to the pKa, more of unionic form will be available. As the pKa is away from the pH, more of ionic compounds will be available. So uptake of the drug by the tissue largely via lipophilic adsorption will also alter the activity by shifting the effective pKa downward, thereby favoring the neutral base form and by limiting the diffusion of the anesthetic away from the site of injection. Here we can see a table comparing the potency with the pKa as well as the hydrophobicity. The commonly used drug like lidocaine have a pKa that is closer to the physiological pH of 7.8. That causes a faster onset of action, but hydrophobicity is less, 366, that causes a relatively less conduction block potency. Highly potent agents like bupivacaine, even though they have a pKa of 8.1, the hydrophobicity is higher, that is 3420, and hence their potency is also higher. Moderately hydrophobic local anesthetics block faster than either hydrophilic or highly hydrophobic ones delivered at the same concentration for the following reasons. The moderately hydrophilic local anesthetics like lidocaine are less bound to the tissues than very hydrophobic drugs like tetracaine, but they are more membrane permeant than hydrophilic ones like 2-chloroprocaine. The highly hydrophobic local anesthetics having higher intrinsic potencies are therefore used in lower concentrations, and their diffusion controlled rate of onset is generally reduced. Coming to lipid solubility. Lipid soluble agents can cross the lipid bilayer of the cell membrane more easily than the agents with pure lipid solubility. Therefore, the highly lipid soluble local anesthetics produce conduction blockade at lower concentration as more molecules reaches the sodium channels and their site of action. Lipid solubility is expressed by the partition coefficient, that is oil to water or octanol to water ratio, and a higher coefficient indicates a greater lipid solubility while a lower coefficient indicates a poor solubility. The solubility of tetracaine is more than bupivacaine, more than ropivacaine, more than chloroprocaine, more than lidocaine and procaine. Coming to the molecular weight. The smaller the molecular weight, the more rapidly the molecules can diffuse through the membranes. Bupivacaine has a higher molecular weight compared to ropivacaine and lidocaine. Protein binding. The local anesthetics with high protein binding, that is to alpha-1 acid glycoprotein, they have a longer duration of action and lower bioavailability. Hypoxia, hypercarbia and acidemia decreases the protein binding and increases the risk of toxicity. In children less than 6 months, they have a less protein binding capacity. For example, bupivacaine has the maximum protein binding capacity, resulting in a higher duration of action compared to ropivacaine, mepivacaine, lidocaine and procaine. Coming to the minimum effective concentration. It is the minimum concentration of local anesthetic that is necessary to produce the conduction blockade of nerve impulses. The nerve fiber diameter influences the minimum effective concentration, with larger nerve fibers requiring higher concentration of La for production of conduction blockade. An increased tissue pH or high frequency of nerve stimulation decreases the minimum effective concentration that is required. Each local anesthetic has a minimum effective concentration reflecting the potency of each drug. The minimum effective concentration of motor fibers is approximately twice that of sensory fibers. Thus, sensory anesthesia may not always be accompanied by a skeletal muscle paralysis. Despite an unchanged minimum effective concentration, less local anesthetic is needed for subarachnoid block than for epidural, reflecting a greater access of LA to the unprotected nerve fibers in the subarachnoid space. So, procaine has a higher minimum effective concentration than lidocaine, ropivacaine, or bupivacaine. Coming to the properties of local anesthetics. First is the potency. So, potency and onset of action is determined by the hydrophobicity. The onset of conduction block in isolated nerve is related to the physicochemical properties of the individual agents. The 0.75% bupivacaine has a more rapid onset than 0.25%. Chloroprocaine demonstrates a rapid onset of action because it is used in high concentrations of 3%. So the potency of lidocaine is, or the onset of action of lidocaine is more than chloroprocaine, more than procaine, more than ropivacaine and bupivacaine. Coming to effective dose 95 and effective dose 50. So it is defined as the dose that is required to produce the effects in 50% of the population to which the drug is administered is the ED50. So these values can vary with the site of injection, the block type as well as the volume. The study has shown that ED50 of hyperbaric bupivacaine ranged from 4.7 mg to 9.5 mg, 9.8 mg, whereas the effective dose in 95% of the population ranged from 8.8 mg to 15 mg. Doses at the level of ED50 minimize spinal anesthesia-induced hypotension, yet it increased the intraoperative pain supplementation, whereas doses at the level of ED95 provided adequate surgical anesthesia with risk of maternal hypotension. In a study for intrathecal levobupivacaine for C-sections, the ED50 was determined to be around 6.5 and ED95 around 12.9. If doses of levobupivacaine less than ED95, particularly near the ED50 are used, these doses should be administered under a combined spinal epidural technique. ED50 of spinal hyperbaric ropivacaine was determined to be around 10.37 mg and ED95 to be 15.39 mg in C-sections. In a study conducted to determine the full dose response relationship of intrathecal bupivacaine, levobupivacaine and ropivacaine combined with sufentanil for labor analgesia, the findings was that the ED95 of bupivacaine was 3.3 mg and the ED95 of ropivacaine and levobupivacaine were 4.855 mg respectively. So this suggests that racemic bupivacaine was significantly more potent than ropivacaine and levobupivacaine, which were of similar potency. Coming to the duration of action. Duration of action is markedly influenced by the peripheral vascular effects of the local anesthetic drugs. They have a biphasic effect on the vascular smooth muscle. At low concentration, local anesthetics causes vasoconstriction, and at higher clinically administered concentration, they causes vasodilatation. The effects of local anesthetics on vascular tone and regional blood flow are complex and they vary according to concentration, time, and the particular vascular bed near the site of application. So bupivacaine has a comparable duration of action to levobupivacaine, ropivacaine, more than mepivacaine, more than lidocaine, more than procaine and chloroprocaine. Coming to differential conduction blockade. So the conduction blockade of local anesthetic is determined by two factors. One is the diameter of the fiber and next is the myelination. So as the diameter is small, the faster the onset of action of local anesthetics, and local anesthetics also act well on the myelinated nerve fibers. So we can understand from this chart that the B fibers, which are myelinated and have a smaller diameter, are the first that is affected, followed by the C fibers, which have a very small diameter but they are unmyelinated. This is followed by the A delta fibers, which are myelinated and has a diameter of about 2 to 5, followed by A gamma, A beta, A alpha in the order of the diameter of the fibers. So order of sensitivity to the blockade clinically will be, initially the preganglionic autonomic fibers will be blocked, followed by loss of sensation to cold, warm, pin prick and pain sensations, followed by touch, deep pressure and vibration and proprioception, and finally the motor that is carried by the A alpha fibers. Coming to the factors that influence the anesthetic property. One is the dosage of local anesthetic. As the dosage of local anesthetic is increased, the probability and duration of satisfactory anesthesia increases and the time to onset of block is shortened. Dosage of local anesthetic can be increased by administering either a large volume or a more concentrated solution. For example, increasing the concentration of epidurally administered bupivacaine from 0.1 to 0.125% while maintaining the same volume of injectate, that is 15 ml, resulted in a shorter latency, improved incidence of satisfactory analgesia, and a longer duration of sensory analgesia. Next is the addition of additives. One is soda bicarb. So addition increases both the onset and duration of action. Faster onset is by making the pH more alkaline so that more drug is available in the unionized form. Later, the carbon dioxide is released from the sodium bicarbonate metabolism that enters intracellularly and makes the intracellular pH more acidic, and hence more drug will be available in ionized form, thereby increasing the duration of action. The addition of soda bicarb decreases the minimum concentration required for conduction blockade. Epinephrine. Vasoconstrictors that decreases the rate of vascular absorption allows more anesthetic molecules to reach the nerve membrane and thus improves the depth and duration of anesthesia. Clinically, the solutions that are used contain about 5 mics per ml or 1 in 2 lakh of epinephrine, reflecting a balance between efficacy and vasoconstriction versus the systemic side effects of epinephrine. The extent to which epinephrine prolongs the duration of anesthesia also depends on the specific local anesthetic use and the site of injection. Advantages of adding epinephrine includes it can prolong local anesthetic duration by reducing the systemic uptake and allows more drug to reach the neurons. It reduces the risk of toxicity because of slower and lower peak plasma levels and also serves as a marker for accidental intravascular injection. Disadvantage is that high doses can cause arrhythmias, cardiac irritation risk increases with concurrent use of inhalational agents. Contraindications are using in blocks involving end arteries like digits, foots, or penis, local infiltration in skin flaps, in cases of severe hypertension, hyperthyroidism, or pregnancy-induced hypertension. Next adjuvant that we are discussing is dexamethasone, and it is the most effective adjuvant for prolonging block duration with minimal side effects. It can be used perineural as well as intravenous. Both has a comparable efficacy. The doses used are between 4 to 10 mg, and the mechanism of action is because it acts on the glucocorticoid receptors on the neuronal membrane, and the expression of inhibitory potassium channel is increased and the excitability of unmyelinated C fibers is decreased. So perineural dexamethasone can cause localized vasoconstriction and following absorption into the vasculature, and this can reduce systemic inflammation as well. The next adjuvant that we are discussing is dexmedetomidine. This is an alpha-2 agonist and they prolong the action of local anesthetic. Adverse systemic effects include hypotension, bradycardia, and sedation. So in the peripheral neurons, dexmedetomidine inhibits on hyperpolarization activated nucleotide gated channels and inhibits the entry of cations and maintains the neuron at a negative potential and hyperpolarized state. The optimal dose at which the duration of sensory block was maximum was 50 to 60 micrograms. Clonidine also causes hyperpolarization of A and C fibers and inhibits further action potential generation. The mechanism of action is similar to that of dexmedetomidine. Buprenorphine, it's a partial mu opiate receptor agonist. It intensifies blockade by two mechanisms. One is the blockade of the kappa and gamma opioid receptors, and also because of the voltage-gated sodium channel blocking properties. So this is a chart prepared by Dr. Hetalsa that I have shared here of an ideal local anesthetic adjuvant. So there are mnemonics like safe, sensory, and motor. So safe is the sensory block quality should be improved. Analgesic duration should be increased with the use of the adjuvant. It should have a fast onset and it should be effective across modalities. Sensory solution should be preservative free. Evidence of dose response should be there. There should be no neurotoxicity, myotoxicity, or chondrotoxicity. Sensory selective prolongation should be there. Optimal mechanism should be defined, and there should be we should use a reduced LA dose with the adjuvant, and interaction with the local anesthetic should be compatible. The motor function should not be prolonged. Onset should be shortened. Toxic effects should be absent, and overall duration should be increased with reproducible effects. Coming to the mechanism of action of local anesthetics. They work by blocking the nerve conduction by inhibiting the influx of sodium ions into the nerve cytoplasm. They decreases the action potential peak, increases the firing threshold, and decreases the impulse conduction and refractory period. So here we can see the structure of a typical sodium channel. So the sodium channel has a alpha subunit as well as a beta subunit. The alpha subunit has 4 domains, that is 1, 2, 3 and 4. This is opened alpha subunit of a sodium channel, and each domain has about 6 segments, that is S1, 2, 3, 4 and 5, 6. And these close and they form a central channel. The channel is formed by the S5 and S6 segments, and the inactivation gate is between the domain 3 and 4, that is the S6 and S1 of the domain 3 and 4. The S4 in each domain has a positively charged arginine or lysine amino acids, and it is the voltage sensitive region of the sodium channel. So here we can see the 3 states of a sodium channel. That is the resting state or the closed state, where there is no entry of the sodium that is allowed. So when an action potential reaches, the resting state has a membrane potential value of around minus 70 millivolt. And when the action potential reaches and there is depolarization, that is minus 55 millivolts is the threshold potential, it causes depolarization and it changes into plus 40 millivolts. So there will be sodium ions that are rapidly entering through this open or activated sodium channels. Later, once it is depolarized, the inactivation gate will close the sodium channel, and this sodium channel will go into an inactivated state. So the local anesthetic has the maximum affinity during the open state of the sodium channel as well as the inactivated state of the sodium channel. The local anesthetics will diffuse through this lipid bimembrane, enter into the intracellular space, and they block the sodium channel from the inside. So they can block when it is in the activated state as well as in the inactivated state. So theories for mechanism of action of local anesthetics. So this one is use dependent blockade or phasic blockade. Higher the frequency of depolarization, higher the number of sodium channels that are blocked. So this is an electrophysiological graph that shows use dependent or phasic block of sodium channels by lidocaine. So we can see that this deflection, negative deflection, is the depolarization of the sodium, depolarization of the nerve membrane. When there is addition of the 0.2 millimoles of lidocaine with 2 impulses, that we can see the depolarization has reduced. As the number or frequency of impulses is more, the depolarization is less. This frequency-dependent inhibition is also called as phasic inhibition. It is reversed when stimulation is slowed or stopped and current returns to the level of tonic inhibition observed in the resting nerve. This is an electrophysiological demonstration of use-dependent block of sodium channel by lidocaine of 0.8 millimoles at a stimulus frequency of 20. As we can see, as the frequency increases, the depolarization or the peak depolarization also decreases in the presence of lidocaine. Coming to the modulated receptor theory. The affinity of local anesthetic for the sodium channel is more in the active state or inactivated state than the resting state. This relationship between the state-dependent affinities and modification of transition among states through drug binding is known as the modulated receptor model. Another theory is the membrane expansion theory. So on injecting a local anesthetic, there is a 3 to 4% expansion of the membrane volume, even though the actual volume of the drug occupying the membrane is 0.3 or lesser. On membrane expansion, there is unfolding of the membrane proteins together with a disordering of the lipid component of the cell membrane with consequent obstruction of the sodium channels. There is displacement of the membrane-bound calcium channels, which also may be involved in the conduction blockade. Coming to the pharmacokinetics. The concentration of local anesthetics in the blood is determined by the amount injected, the rate of absorption, the rate of tissue distribution, and the rate of biotransformation and excretion. Some patient-related factors like age, cardiovascular status, hepatic function also influences the physiologic disposition and resultant blood concentration of local anesthetics. The absorption of a local anesthetic is determined by the site of injection, the dosage, volume, addition of a vasoconstrictor agent, the pharmacological profile of the agent itself. Comparing the blood concentration after various routes of administration reveal that the concentration is the highest in intravenous, followed by intrapleural, intercostal, caudal epidural, lumbar epidural, brachial plexus, subarachnoid, and subcutaneous. Distribution. The systemic distribution of local anesthetics can be described sufficiently by a two-compartment model. The rapid disappearance phase is believed to be related to the uptake by rapidly equilibrating tissues with high vascular perfusion, and the slower phase of disappearance from blood is a function of the particular compound, and the primary extraction takes place in the liver, but local anesthetics are also rapidly extracted by the lung tissue. So coming to the biotransformation and excretion of local anesthetics, esters or procaine-like drugs are hydrolyzed in the plasma by pseudocholinesterase enzymes. Amino amides are degraded in the liver primarily, and they are excreted via the kidneys. The factors that can affect the pharmacokinetics are: one is age. Infants have a decreased alpha-1 acid glycoprotein that can result in high free drug concentration. They also lack early warning signs of local anesthetic toxicity, so extra caution is needed. In low cardiac output states, like hypovolemic shock or heart failure, there is a reduced hepatic blood flow, and so amide local anesthetic metabolism decreases. In pregnancy, there is increase in progesterone levels that make them more sensitive to local anesthetics. Poor nutrition, cachexia also reduces the alpha-1 glycoprotein levels. So coming to the pharmacological effects, they can have local effect, that is nerve blockade and direct effect on smooth muscles. Regional, there can be loss of pain and temperature sensation, touch, motor power, vasomotor, tone in the region supplied by the nerves blocked. Systemic effects can occur as a result of systemic absorption or IV administration. On cardiovascular system, lignocaine and procaine have a stabilizing effect on the cell membrane of cardiac tissue. They tend to depress automaticity in abnormal or damaged fibers and thereby suppresses the dysarrhythmias. They also prolong the action potential duration, thus increasing the effective refractory period of cardiac cells, slowing the conduction, so desynchronizing ventricular contraction with a consequent depressant effect on the myocardial contractility. Cocaine has a stimulant effect on the CNS, which is unrelated to its local anesthetic action. Synthetic local anesthetic agents can produce sedation and lightheadedness. However, anxiety and restlessness can occasionally occur. So this reflects a greater susceptibility of the inhibitory neurons compared to the excitatory neurons to depressive effects. With more marked toxicity, the patient can notice a numb tongue, circumoral pins and needle sensation, twitching and visual disturbances. Severe toxicity proceeds to convulsions and coma with respiratory and cardiac depression as a result of medullary depression. Vascular smooth muscle, we already discussed. The effect is local, regional, or systemic. Local effects vary while procaine is a vasodilator, cocaine is a vasoconstrictor. Vasoconstriction is frequent at lower concentration and vasodilatation at higher concentration. Autonomic nervous system, cocaine inhibits the catecholamine uptake and has a sympathetic potentiating effects, whereas other local anesthetics do not have this function. They have a weak blocking action on the cholinergic and adrenergic receptors, and this cholinergic blocking action accounts for the bronchodilator effect of local anesthetics. Neuromuscular junctions, at doses, they can also block motor nerves if present in sufficient concentration. Dermatitis can be encountered as a delayed reaction to skin applications. Cross-sensitivity can occur between local anesthetic, which reflects a common metabolite, that is para-aminobenzoic acid, but this does not occur between classes of local anesthetics. Like a patient with non-allergy to ester can receive an amide. This is a table comparing the commonly used local anesthetics, that is lignocaine, bupivacaine, and ropivacaine. We know that they are tertiary amides. The protein binding of lignocaine is just 64% compared to 95% of bupivacaine and 94% of ropivacaine. They all are metabolized by hepatic metabolism and they are excreted via urine. And the factors that affect metabolism we have already discussed. The onset of action for lignocaine is about 2 to 20 minutes, with 10 to 20 minutes for bupivacaine and ropivacaine about 10 to 15 minutes. Duration of action is about 1 to 3 hours for lignocaine, 2 to 8 hours for bupivacaine, and 3 to 6 hours for ropivacaine. Potency, intermediate potency for lignocaine, high potency for bupivacaine. Ropivacaine is slightly less than bupivacaine. Cardiotoxicity is moderate with lignocaine, high with bupivacaine, and lower than bupivacaine with ropivacaine. So these are the different concentrations that are available. This is a local anesthetic 2% lignocaine that's available. This is with adrenaline, and this is a preservative-free local lignocaine that is available. 0.25% bupivacaine and 0.5% bupivacaine. This is 0.2% ropivacaine and 0.5% ropivacaine. Coming to the topic of interest, that is, can we mix local anesthetics? In a study that was published in Indian Journal of Anesthesia by Dhar et al., they compared block characteristics of a mixture versus sequential injections of lignocaine and ropivacaine for supraclavicular brachial plexus block, and they observed that sequential injection of lignocaine and ropivacaine had a higher initial rate of sensory and motor block onset. However, they both had similar total block and analgesia duration. Whereas in a study by Supriya et al. In RAPM, it was observed that equal mixture of 2% lignocaine with adrenaline and 0.5% bupivacaine 20 ml provided a faster onset of complete conduction blockade during ultrasound guided supraclavicular brachial plexus block than 20 ml of 0.5% bupivacaine alone. But they observed that there is a longer duration of postoperative analgesia compared with lidocaine alone, but shorter than bupivacaine alone during the blockade. Coming to the uses of local anesthetics, as we all know, they can be used for central neuraxial blockade like epidural anesthesia. Lignocaine can be used with or without epinephrine. Longer acting agents like bupivacaine, levobupivacaine, ropivacaine are also commonly used. Spinal anesthesia, lidocaine, bupivacaine, ropivacaine, levobupivacaine are used. Dosage can vary according to the height of the patient, segmental level desired, and duration of anesthesia that is desired. Peripheral nerve blockade can be achieved by injection into tissue surrounding the individual peripheral nerves or nerve plexus such as the brachial plexus. When they are deposited in the vicinity of a nerve, they diffuse from the outer surface towards the center of the nerve along the concentration gradient. The duration depends on the dose of the local anesthetic, lipid solubility, protein binding, and concomitant use of vasoconstrictors such as adrenaline. Another use is intravenous regional anesthesia, also called as the Byers block. In this, there is injection of a local anesthetic solution into an extremity that is isolated from rest of the circulation by a tourniquet, which provides a rapid onset of anesthesia and skeletal muscle relaxation. The duration is independent of the specific local anesthetic, and it is determined by how long the tourniquet is kept inflated. Exact mechanism is not sure, but it is mostly because of the effect of the drug on the nerve endings. Normal sensation and skeletal muscle tone return promptly on release of the tourniquet that allows blood flow to dilute the concentration of the local anesthetic. Lignocaine is most commonly used for intravenous regional anesthesia. Alternatives are prilocaine, mepivacaine, ropivacaine. In general, about 3 mg per kg, that is 40 ml of a 0.5% solution of preservative-free lidocaine without epinephrine is used for upper extremity, whereas 50 to 100 ml of a lower concentration lidocaine is used for lower extremities. Local anesthetics are used for topical or surface anesthesias. Local anesthetic can be placed on the mucous membrane of nose, mouth, tracheobronchial tree, esophagus, or genitourinary tract. Prilocaine, tetracaine, lidocaine are most commonly used. Nebulized lidocaine is often used to produce anesthesia of the upper and lower respiratory tract. This is a LOX 10% spray that is used for providing local anesthesia to the posterior pharyngeal wall during fiber optic bronchoscopies. These are the various preparations that are available for topical anesthesias. Coming to the eutectic mixture of local anesthetics, lidocaine and prilocaine cream, that is 2.5% each concentration, allows the use of high concentration, and this is considered as eutectic as the melting point of the combined drug is lower than lidocaine or prilocaine alone. They act by diffusing through the intact skin to block the neuronal transmission from the dermal receptors. Usually 1 to 2 gram is applied per 10 centimeter square area of skin, and it is covered with an occlusive dressing. It's effective in relieving pain of venipuncture, arterial cannulation, lumbar puncture, and myringotomy. About 45 minutes is suggested as the minimum effective onset time, but a significant decrease in pain scores is noted after only 5 minutes. Complications are EMLA application on raw areas can lead to systemic toxicity and methemoglobinemia. Reports of seizure, respiratory distress, and methemoglobinemia in infants, especially less than 3-month-old, have been reported. Tumescent anesthesia is another use. It is most commonly used by plastic surgeons during liposuction, involves subcutaneous injection of large volumes of local anesthetic in combination with epinephrine and other agents. The total dose of local anesthetic range from 35 to 55 mg per kg to produce safe plasma concentration around or below 5 mics per ml. The solution is very dilute, and epinephrine reduces the local blood flow and systemic absorption. Most of the anesthetic remains in the subcutaneous tissue and is removed with aspirate when liposuction is performed. Coming to advancements in local anesthetics, the current focus is on controlled release local anesthetics. The goals of these local anesthetic carrier systems is that they provide a local depot at the target site that can prolong the effect, which can reduce the systemic and local toxicity, enhances the tissue permeability and absorption, and also influences the onset, spread, block intensity, and duration of action. So they can be encapsulated in liposomes, they can be complex with cyclodextrins, or they can be bound with biopolymers. Also available as transdermal non-liposomal carriers. So topical LA delivery systems uses adjuvants such as viscosity agents, preservatives, permeation enhancers, and emollients. It's available in various pharmaceutical forms like semi-solid, liquid, and solid. So currently liposome-based local anesthetic formulations are available. These are biodegradable, non-toxic phospholipid vesicles, and they provide controlled and sustained drug release. Mechanism is a slow diffusion of local anesthetic from lipid bilayers, which extends the duration of action and maintains a local concentration and reduces the systemic toxicity. Benefits are they prolong the anesthesia duration, decreases the toxicity, suitable for various local anesthetic types. Limitations are they are physically and chemically unstable, they can undergo oxidation or they can aggregate, very expensive, complex formulation, and there is limited clinical data for regional use. One technology is the Dipoform technology, that is the multivesicular liposomes with multiple aqueous chambers that are separated by lipid membranes. This allows high drug loading and controlled release over 1 to 30 days without altering the drug structure. The release rate can be adjusted by lipid or aqueous composition. The routes include subcutaneous, intramuscular, epidural, intrathecal, or intraarticular. FDA has approved two products, that is Deposide, that is cytarabine, and Exparel, that is bupivacaine. They are ready to use and even compatible with small gauge needles and pen systems, provides immediate release followed by sustained delivery, and they contain less than 3% biodegradable lipids, that is phospholipids, cholesterol, and triglycerides. They are clinically safe to use with minimal side effects, that is shown in trials, and reduces systemic toxicity by lowering the peak serum levels. So this is an electromicrograph picture of the depot form. So you can see there are chambers filled with medication, and they have a lipid layer. So liposomal bupivacaine that is currently commercially available is Exparel. It was FDA approved in 2011 for single injection surgical site infiltration, and it can provide analgesia up to 72 hours compared with 7 hours of plain bupivacaine. It has been observed. It has been studied in soft tissue surgeries like hernia, hemorrhoidectomy, breast surgery, and orthopedic surgeries like bunionectomy and TKA procedures for local infiltration. It is supplied as 1.3% single-use vial. It can be either 20 ml or 10 ml. There is only 3% of free bupivacaine, and it can produce two plasma peaks, that is one is at 1 hour and 12 hours. Duration of action of bupivacaine is around 24 hours, and it undergoes hepatic metabolism similar to standard bupivacaine. So clinical evidence is available for hemorrhoidectomy and hernia repair, where it reduced the pain and opioid use up to 72 hours. Bunionectomy and breast surgery also, there was early pain control versus placebo or plain bupivacaine. Total knee replacements, mixed results. Some studies show no superiority to bupivacaine hydrochloride or ropivacaine. And it has been FDA approved for use of interscalene brachial plexus block as well. Experimental uses, peripheral nerve blocks, it is not FDA approved yet. Studies show a prolonged blockade of more than 24 hours without neurotoxicity. Side effects include mild nausea, pruritus, constipation. Limitations include the delayed onset, reduced early analgesia, and prolonged motor blockade that can result in increase in fall risk in elderly population. Epidural use, it is in investigational only. In the phase 1 trials, there has been longer sensory block with lesser motor blockade when compared with plain bupivacaine. Then coming to the polymeric micro and nanoparticle formations, these are made of natural and synthetic biodegradable polymers like polylactic acid, polyglycolic acid, polylactoglycolic acid, etc. They act as carriers for various drugs, including local anesthetics, and they enable site-specific sustained and controlled release. Polylactoglycolic acid as a carrier, they are FDA-approved biodegradable polymers and hydrolyzers to lactic and glycolic acid, which are metabolized via the Krebs cycle. They offer protection from degradation and allow surface modification for targeting. They have a preferential uptake by reticuloendothelial system, so it is useful for inflamed tissues. Benefits are they are biocompatible and biodegradable. They have a prolonged duration of action and reduce systemic toxicity. They have improved encapsulation and so provides a sustained drug release. Limitations are stability issues. These nanoparticles are prone to aggregation and so they will require freeze drying, variable encapsulation efficiency, complex production and characterization challenges. Some experimental medications include saber-bupivacaine. Saber is sucrose acetate isobutyrate extended release. They are bioerodible injectable depot delivering drugs over days to 3 months. Formulation contains sucrose acetate isobutyrate additives and solvent. It is a viscous hydrophobic sucrose ester that can be injected subcutaneously or intramuscularly using less than 25 gauge needles. So it is developed and it is pending FDA approval. Coming to bupivacaine collagen implant, it is called as Zaracol. Implantable collagen matrix for post-operative analgesia at surgical sites. They are biodegradable and resorbable collagen impregnated with bupivacaine. They provide controlled, sustained release of local anesthetics. Clinical evidence include it is used in hernia repair and reduced pain scores in first 24 to 48 hours and also the opioid use. The effect can last up to 72 hours post-operatively. Side effects include constipation, nausea and headache and mild elevation on transient elevation of liver enzymes has been noted. No clinically significant systemic toxicity. It is awaiting phase 3 approval. So this is a sponge and this is a membrane infused with local anesthetic. Coming to the last topic, that is the local anesthetic systemic toxicity. It is because of the excess plasma concentration of local anesthetic and it is determined by the rate of drug entrance into the systemic circulation relative to their redistribution into inactive tissue and clearance by metabolism. It can be because of the accidental intravascular injection, which is the most common mechanism for production of excess plasma concentration of local anesthetics. The magnitude of this systemic absorption can depend upon the dose administered, the vascularity, the presence of epinephrine in the solution, as well as the physicochemical properties of the drug. Usually, we add about 5 mics of epinephrine to every ml of local anesthetic, that is 1 in 2 lakh dilution. It decreases the systemic absorption by approximately 1/3. So these are the maximum recommended doses of local anesthetics as derived from Stalting's anesthesia. We can see that lidocaine is without epinephrine, it is around 5 mg per kg and with it is 10 mg per kg. Bupivacaine is without 2 mg per kg and maximum is 3 mg per kg with adrenaline. Levobupivacaine 3 without adrenaline and 4 mg per kg with adrenaline. Ropivacaine about 3 mg per kg without adrenaline. And the mg per kg are calculated based on the lean body weight. Coming to the cardiovascular collapse CNS ratio, this is the ratio. This describes the dose that is required to produce cardiovascular arrhythmias versus that is required to produce seizures. So if the ratio is lower, it implies a reduced safety margin for local anesthetic compounds compared with a higher ratio to detect impending cardiotoxicity based on the premonitory CNS signs. So this ratio is higher for lidocaine, that is 7.1 plus or minus 1.1, whereas for bupivacaine it is around 3.7 plus or minus 0.5. The cardiovascular collapse CNS blood ratio, the concentration that was found in the blood during toxicity for lidocaine was 3.6 plus or minus 0.3 and for bupivacaine it was 1.6 plus or minus 0.7, showing that bupivacaine is highly cardiotoxic and has a low margin of safety. So this is the effective dose 50 of lidocaine and the lethal dose of 50, in 50% of population for lidocaine. And we can see that the safety margin is higher with a therapeutic index of 10 to 12. Whereas in bupivacaine, it is very less. The therapeutic index is 6 to 8. Coming to the effects of CNS, low plasma concentration of local anesthetics are likely to produce numbness of tongue circumoral tissues because of the delivery of drugs to these highly vascular tissues. So the dose-dependent effects of lidocaine include 1 to 5 there is analgesia, 5 to 10 there is circumoral numbness, that is mics per ml. There is circumoral numbness, tinnitus, skeletal muscle twitching, systemic hypotension and myocardial depression. 10 to 15 mics per ml there will be seizures and unconsciousness. 15 to 25 there can be apnea and coma, and more than 25 there can be cardiovascular depression. So it is compromise of many initial prodromal features and most often manifest as seizures. One theory is centered around the TAS channel, that is TWIC related acid sensitive potassium channels that are pH sensitive channels which generate neuronal potassium leak currents. So they are potassium leak channels that maintains the resting membrane potential. Normally, continuous potassium efflux occurs through these channels that maintain the neuronal stability. Because of local anesthetic, they inhibit these channels and there will be decrease in potassium efflux which maintains the membrane in a depolarized state. What is the result? There will be increase in neuronal excitability resulting in uncontrolled loss of inhibition, uncontrolled firing, and finally seizures. Another explanation for seizures is local anesthetic induced inhibition of the release of neurotransmitters, especially GABA. The plasma concentration of local anesthetics that produces signs of CNS toxicity also depends on the specific drug that is involved. Lidocaine, mepivacaine, prilocaine demonstrate the effects at plasma concentration of about 5 to 10 mics per ml, whereas the typical concentration of bupivacaine is about 4.5 to 5.5 mics per ml. The factors that affect the CNS toxicity, first is potency as we have discussed. Lidocaine, it is 5 to 10 mics per ml. Bupivacaine, the seizures occurs in about 4.5 to 5. The rate of drug administration, that is rapid rise in plasma concentration, lowers the threshold for CNS toxicity. Respiratory and metabolic acidosis. Acidosis decreases the toxicity threshold, reduces the protein binding, and increases the more free drug that is available, causing CNS toxicity. Plasma clearance. Esters are cleared by pseudocholinesterase. So in deficiency, that amount will increase. Amide local anesthetics, clearance can be reduced in liver diseases or in low hepatic blood flow, like low cardiac output states. Also, because of the toxic effects of different LAs are addictive. So amides and esters can add up. Other CNS depressants agents like thiopentone and midazolam can increase the seizure threshold and reduces the LA-induced CNS toxicity. Coming to cardiac toxicity, it is because of the blockade of the cardiac sodium channels that leads to negative inotropy and arrhythmia. It decreases the conduction in the Purkinje fibers and cardiac myocytes that prolongs the recovery time. There is reduction in rate is believed to be a decrease in the availability of fast sodium channels in cardiac membranes. They also have direct peripheral vascular effects. Local anesthetic exert biphasic effects on the peripheral vascular smooth muscle. Low concentration causes vasoconstriction, high concentration produces vasodilatation. In ECG, we can see there is an increase in the PR interval and duration of the QRS complex. The extremely high concentrations even can depress the spontaneous pacemaker activity of the sinus node, resulting in bradycardia and arrest. So bupivacaine follows a fast in slow out fashion, that is, it binds very quickly to the sodium channels during cardiac action potential, but releases from the channel slowly during the diastole, resulting in a large proportion of the medication to accumulate. Whereas lidocaine follows a fast in fast out principle, means it releases from the sodium channel rapidly during diastole. Factors that affect cardiotoxicity are pregnancy. Increased progesterone level enhances the tissue sensitivity to local anesthetics. Reduced protein binding, there will be reduced alpha-1 glycoprotein levels resulting in decreased protein binding. High free drug levels are available resulting in more binding to the cardiac sodium channels. Concomitant use of beta blockers, calcium channel blockers, and digitalis lowers the threshold for cardiac toxicity. Acidosis and hypoxia potentiates the cardiodepressant effects of local anesthetics. In case of tachycardia, there is frequency-dependent increase in sodium channel blockade by bupivacaine. Bupivacaine, the racemic mixture causes more cardiotoxicity than the pure S enantiomers. Coming to the local anesthetic systemic toxicity in pediatrics, so the pediatrics, it is little more challenging because the clinical manifestations occur under general anesthesia. Mostly we give the regional block under general anesthesia, and so the CNS symptoms can be masked and the cardiac signs can predominate like bradycardia, hypotension, QRS widening, ventricular arrhythmias or cardiac arrest. In pediatrics, we commonly use, it lasts is more because mild local anesthetics are commonly used. Ester local anesthetics are metabolized by plasma pseudocholinesterase, offering a short duration and low toxicity. So if prolonged infusions are required, chloroprocaine is preferred in infants due to rapid metabolism and good safety profile. Infants less than 12 months have a higher risk. Immature hepatic and renal because of the immature hepatic and renal metabolism, low alpha-1 glycoprotein levels, and high free drug levels as well. Penile nerve block carries a higher risk, the incidence of about 0.075% due to rich vascularity and proximity to the dorsal veins. The toxicity can occur even with safe doses. So in pediatrics, we have to use the lowest effective dose and take out and carry out all the safety measures. like aspiration. Aspiration alone has a sensitivity, a low sensitivity, and epinephrine test dose should be used in sevoflurane anesthetized children as it detects intravascular injection with 94 to 97% sensitivity. Ultrasound guidance further reduces the risk. So this is a chart that is showing the local anesthetic systemic toxicity, that is, we can see from here that in cases of usage of ultrasound with low doses and less lipophilic local anesthetics, the risk of blast is lower. Whereas when we use no ultrasound, higher doses and more lipophilic local anesthetics, the risk of local blast is more, especially in patients who are compromised, like elderly, neonates, patients with cardiac diseases and metabolic diseases. Coming to the management of local anesthetic systemic toxicity. So once you suspect there is local anesthetic systemic toxicity, immediately you have to call for help, get the last rescue kit and consider a cardiopulmonary bypass team. If there is a seizure, we have to first secure the airway and benzodiazepine is usually preferred to control the seizure activity. If only propofol is available, we have to use low dose, that is about 20 milligram of increments. In case of arrhythmia or hypotension, the resuscitation differs from the standard ACLS protocol. Epinephrine is used in a dose smaller than usual, with starting with a dosage of less than 1 mics per kg. We should avoid usage of local anesthetic, beta blockers, calcium channel blockers or vasopressin. And coming to intravenous lipid emulsion, it has to be started early. So 20% lipid solution is available. If the patient is over 70 kg, bolus of 100 ml has to be given over 2 to 3 minutes and infusion of 250 ml should be given over 15 to 20 minutes. In a patient under 70 kg, 1.5 ml per kg has to be given over 2 to 3 minutes and 0.25 ml per kg per minute has to be given as an infusion over 15 to 20 minutes. If the patient remains unstable, we have to repeat the bolus and also double the infusion. If the patient becomes stable, then we have to continue the lipid emulsion for about more than 15 minutes, and the maximum lipid dose that can be given as infusion and bolus together comes to about 12 ml per kg. Once the patient is stable, we have to observe the patient closely for about 2 hours after seizure, 4 to 6 hours after cardiovascular instability, and as appropriate after cardiac arrest. This is our AORA guidelines regarding the local anesthetic systemic toxicity. So step 1 is to stop the anesthetic injection, call for help and activate the cardiopulmonary bypass team. We have to secure the ABC, that is airway, breathing and circulation. The drugs that have to be avoided already mentioned. Intravenous lipid emulsion therapy has to be started, and we can give up to maximum 3 boluses and maximum of 12 ml per kg dose. In pediatrics, the dose is around 1.5 to 2 ml per kg. So the last severity also depends on the location of injection. Venous injection causes a gradual CNS toxicity followed by cardiotoxicity. Central arterial injection like subclavian artery or injection or vertebral artery injection causes catastrophic CNS and cardiac collapse in seconds. Peripheral arteries causes a local ischemia and there is a delayed systemic toxicity. So cardiopulmonary bypass team has to be activated immediately if we are suspecting a severe reaction. And ECMO should be considered for severe unresponsive cases of LAST, as it is a potentially treatable cause of cardiovascular collapse with good prognosis if treated. Coming to lipid emulsion 20%, the components are 20% of soybean oil containing triglycerides like linoleic acid, oleic acid and palmitic acid. There are 1.2% of egg phospholipids, glycerin for about 2 to 2.5%, and pH is around 6 to 8.9. The mechanism of action of lipid emulsion includes lipid sink effect. So this lipid emulsion acts as sequesters for lipophilic drug molecules into an expanded plasma lipid phase and reduces the tissue drug levels in the cardiac tissue as well as the CNS tissue. They act as a lipid shuttle and removes the local anesthetic from the heart and brain and redistributes to the liver and the muscle tissue. They can restore the mitochondrial function of cardiac myocytes, and lipid emulsion also provides fatty acids that can enhance the cardiac energy substrate availability. They also have a direct inotropy effect. They can improve cardiac contractility independently by activation of the calcium channels. Some side effects of lipid emulsion include pulmonary toxicity, ARDS, acute pancreatitis, and fat overload. Certain drugs have to be avoided in blast. That includes beta blockers. Beta blockers reduces the cardiac contractility and heart rate and also decreases the ability of the heart to maintain perfusion, also decreases the ability to maintain the perfusion pressure to the heart, and this can worsen the conduction blockade in the event of a LAST. Calcium channel blockers increases the AV block and conduction slowing and decreases the contractility and blood pressure. It increases the risk of refractory hypotension in LAST. Vasopressin can increase the systemic vascular resistance. There is no improvement in contractility in studies and this causes reduced cardiac output and increases the acidosis. Propofol, cardiodepressant properties of the propofol can worsen the myocardial depression. High dose epinephrine causes excessive beta stimulation resulting in tachyarrhythmias and also increase in afterload and decrease in forward flow, so reducing the success of the lipid emulsion therapy. Small doses, that is less than 1 mg per kg, are acceptable. Sodium channel blocking antiarrhythmics like lidocaine, procainamide have to be avoided. Because LAST already involves severe sodium channel blockade, additional blockade can worsen the conduction block and arrest. Amiodarone is preferred for ventricular arrhythmias. Other side effects of local anesthetic include methemoglobinemia. It's a rare but life-threatening complication with decreased oxygen carrying capacity of the hemoglobin following administration of certain drugs like prilocaine, benzocaine, cetacane, lidocaine, nitroglycerin, phenytoin, and sulfonamides, which can cause oxidation of hemoglobin to methemoglobin more rapidly than methemoglobin is reduced to hemoglobin. Neonates are at a higher risk because of the readily oxidized fetal hemoglobin that is available. Treatment is by administering methylene blue 1 to 2 mg per kg IV over 5 minutes. Total dose should not exceed 7 to 8. Allergic reactions are common to esters due to the presence of para-aminobenzoic acid, and it is possible to amide local anesthetics also because of the presence of methyl paraben as a preservative. Neurotoxicity, direct neuronal injury due to high concentration, prolonged exposure, or intravascular injection of local anesthetics is noted. The mechanisms include membrane disruption, mitochondrial dysfunction and apoptosis, ischemia from vasoconstriction. High risks are usage of high concentration, acidic and preservative containing solution as well as intraneural injections. Another side effect noted with local anesthetic is transient neurological symptoms. This is a reversible pain or dysphagia in the buttocks, thighs or lower limbs after recovery from spinal. It appears within a few hours to 24 hours post anesthesia and resolves in 2 to 5 days. Mechanism is because of the neural membrane irritation, maldistribution of local anesthetic in the CSF, and patient positioning. Risk factors are high concentration. It is more seen in spinal anesthesia versus epidural, in outpatient procedures involving lithotomy or knee arthroscopy positions. Treatments include opioids, anti-inflammatory drugs, as well as muscle relaxants. Next is an anterior spinal artery syndrome. It is the ischemic injury to the anterior two-thirds of the spinal cord that is supplied by the anterior spinal artery. It causes hypotension or spinal cord hypoperfusion after a spinal or epidural anesthesia, causes the vasoconstrictors or neurotoxic local anesthetic concentration that we have administered, or it can be a surgical or a vascular compromise. Features include motor paralysis below the lesion bilateral and loss of pain and temperature sensation with preserved dorsal column function like touch, vibration, and proprioception. Prognosis is variable recovery and often incomplete. Management is to provide supportive care, maintain the spinal cord perfusion, oxygenation, and avoid hypotension. These are my references. Thank you.
Excellent presentation, Gauri.
Thank you, sir.
Wow, exhaustive presentation.
Yeah, she has covered almost all the points.
Yeah, for the complications of LA, side effects of LA, everything is covered. The questions that I had in mind, she has already covered. Just one thing I want her to repeat is what is the uh, how does the onset of action happen?
Sorry, sir, I did not get your question actually.
How is the onset of action of LA? Onset of action, how does it happen?
The mechanism of action, you are.
The mechanism of onset of action. Yeah.
So when there is the local anesthetic will initially diffuse through the lipid bilayer of the cell membrane, sir, the neuronal cell membrane. It reaches into the cytoplasm and it divides it. It becomes the ionized form inside the acidic pH because of the acidic pH. This ionized form, when the sodium channels open, it will bind from the inside into the sodium channels. and further block the
Correct.
inflow of the sodium via the sodium channels, causing so that there is depolarization will be blocked. There is no conduction after the local anesthetic bind with the sodium channel.
Correct. So it binds to the sodium channels and keeps it at the inactivated state.
Yes.
Correct. So I'm telling onset of action. How the onset of action is affected by the local anesthetic. What is the mechanism? I am stressing on the point that the nerves are myelinated and unmyelinated. So what is the difference and how it uh, does happen?
So
And why the onset of action is different for different local anesthetics?
So the onset of action mainly depends upon the concentration of the drug that is delivered. So if you are
Very
delivering
good.
a higher concentration of the drug, say for example 0.5% of bupivacaine if you use, it has a faster onset of action compared to a 0.25% because more number of molecules are available at the neuronal site.
Great.
Next is the size of the molecules that we are delivering. So smaller size local anesthetics like say lidocaine or compared to bupivacaine, it has a smaller size. So they have a faster onset of action. Next, coming to the
Good.
thickness of the nerve. So thick
Hmm.
nerves will take more time for the nerve, to local anesthetics to reach the nerve membrane and to diffuse through the content of the nerve tissue, and it will take more time to act. Myelination is because when there is myelination, only the nodes of Ranvier, where there are no myelin tissue present, has to be deactivated by the local anesthetic. So less local anesthetic is only required to block these nodes of Ranvier. Whereas in an
Hmm.
unmyelinated nerve fiber, all the area has to be blocked by the local anesthetic.
Okay, so there is a small difference to it. For a myelinated nerve, you have to block at least
2
three
to 3
consecutive nodes,
consecutive. Yes, sir.
at
2 to
least
3
three consecutive nodes of Ranvier. Below that, there will be a jump of the action potential. Whereas in myelinated, it has to be a long segment of the unmyelinated nerve. So the volume will also be dependent. The volume will also depend the onset of action of the unmyelinated nerve fiber blockade. Got it?
Yes, sir.
So that is why there is a differential conduction blockade, which you already told us. Right. So
Gauri, which block has the highest chance of, local anesthetic systemic toxicity?
Sir, the intrapleural or intratracheal administration, like obviously intravenous is the highest risk, followed by
That is fine. Which
yeah,
block? Which block?
intercostal nerve blocks, which we commonly use, have a high toxicity risk, sir.
So suppose if you are giving TAP block, when there are high chances of local anesthetic systemic toxicity?
In a TAP block, sir.
Yeah.
So in a TAP block, if we are using a high concentration, if we are using a continuous catheter technique, if we
Mhm.
are using it in a debilitated patient or any patient with, any metabolic disorders, hepatic problems, or in infants, there is a high risk of local anesthetic systemic toxicity, sir.
Another important point is if you inject the drug intramuscular rather than injecting in the TAP plane, there are higher chances, because if you inject the drug intramuscular, absorption will be faster and you are injecting higher volume
Yes, sir.
because it is a volume dependent block.
Block,
So
yeah.
when you are giving TAP block, you have to be very careful that you are injecting in the right plane and you are using a lower concentration of the drug because it is for somatic analgesia only. So you have to reduce the concentration of the drug and you have to be very careful that you are in the right plane. So for any facial plane block, you have to be very careful that you are in the right plane. So local anesthetic systemic toxicity depends on the if you talk about milligram per kg doses or such things, it is not always there. Like suppose if you are using it for liposuction, you can use high doses of xylocan with adrenaline or ropivacaine or bupivacaine because absorption is very slower. So you don't get any local anesthetic systemic toxicity in spite of using higher volume of the drug and higher concentration of the drugs. So you have to check whether where you are depositing the drug. Like suppose if you are giving intercostal nerve block or paravertebral block or any block in the neck area, like interscalene block or supraclavicular, absorption will be faster and there are higher chances of toxicity. So these are also important factor while calculating that drug dosage in any patient. Remaining factors you have already mentioned. Any questions from fellows?
Dr. Heatal, good evening. This is Ramkumar
Yeah,
here.
yeah. Good evening, sir.
Good evening,
See,
sir.
good evening. I just want to add one thing. I think regarding this toxicity, I think if you read about pediatric blocks, the head and neck blocks, as you were mentioning, the scalp blocks or the scalp, this thing will have a highest toxicity because, we are very close to the vessels and it's a richly vascular. Whatever we see on the ultrasound is very minimal. So when we go through the literature, they have one of the highest incidence of toxicity with very less volume of drugs involved. So we need to be careful when we are doing this because it's even when cervical plexus blocks, overall the head and neck blocks. So I think that also we should be careful of. Yeah.
Agreed, sir.
Yes, sir. Agreed, agreed. So a pediatric, but the reported is penile block. The most common block with LASD reported is penile block for pediatric cases, if I'm not wrong. But agreed, we have to be careful with these scalp blocks and head and neck blocks. That is for sure.
Yeah, Gaurav. But you know what? The penile blocks, yes, because of the rich vascularity. But I think I have read about this in one of the pediatric anesthesia books where when you read about head and neck blocks, they give a word of caution like that. So, I think we need to be
Right.
careful, volume wise and concentration wise, and we go over enthusiastically when we are doing. For example, as always been mentioned, in interscalene block, we should always see the vertebral artery, where it is coming
Correct.
and how it is going. So if our that's where I think over a period of last 2 decades we have transformed from in plane to out of plane to in plane techniques where if you don't see the tip of the needle, because if you go back to the literature and see, many of the catastrophes have happened probably because of over enthusiastic stimulating of the nerves and without ultrasound and without seeing the needle tip, probably that would have led on to catastrophe. So I think wherever we have a chance, I think we should do in plane techniques and see the tip of the needle, so that this negative aspiration, as it's been clearly proven that it is not foolproof for intravascular injection. So we should be very careful, and our eyes should be watching for any halo hypoechoic areas suspecting blood vessels. So I think that we should be very careful in that.
Completely
Vishali
agree,
ma'am,
sir.
Nita ma'am, any comments from you?
I think Rushali ma'am is here. I just want to ask
Yeah.
one question
Sure.
regarding the any updates on ECMO in pediatric, because when we were searching the literature, it was found like pediatric ECMO is not easy. It carries a lot of expertise, and the time given by the kids will not be so much even to initiate that even in the very well equipped places. So any guidelines are coming up or anything is on the already there?
Vishali
The
ma'am, are you
question,
there?
yeah.
Yeah.
The question is on dot. Yes, this is a predicament in children. So obviously, we believe that prevention is far better than treating last. We also believe in aliquots, and we also believe in rate of injection, and we also believe in scrupulous calculation of dosages, milligram per kilogram and ml per kilogram as well. Um, However, there is if there is anything that we really bank upon at the end when we cannot do anything much is a bypass. Sometimes that's yeah. ECMO, as you said. I mean, both of them are extremely difficult in children.
Yeah, bypass can be a bridge from the event to the ECMO, because because it may
Yeah.
not be easily, the cannulas and everything may not be easily available, so we
Yes.
can go on a bypass and do it. Yes, but it's a very challenging thing. Small kids, and I know with
Yes.
all the precautions we can end up in problems. Yeah. That's
Yeah.
any guideline coming up, ma'am?
Not,
Anything?
I mean, not for ECMO at least. The guidelines remain the same for LAST. However, we do step up the dose as not 1.5 ml per kilogram, but 2 ml per kilogram as intralipid in at least infants and small babies. I mean, neonates and infants. That is the thing. And there are many case reports who are who have calculated the dosages in this fashion.
All right. Thank you.
Thanks.
In
Thank
pediatric
you, ma'am.
patient, if I share my experience, I have left pediatric practice since many years, but I had a case of tracheoesophageal fistula. Baby was, I think, 2 days old, and at the end of surgery, surgeon infiltrated at the incision site with bupivacaine, and patient at the last patient went into arrest. At that time, there was no concept of, intralipid, and unfortunately, in that hospital, defibrillator was also not working. We continued almost for half an hour, and to our surprise, luckily, patient uh, recovered well, and the patient went home without any neurological deficit. So, good CPR is also important in pediatric patient. Any comments on it, Vrushali ma'am?
Yeah, yes, that's a very good point.
Yeah, good and prolonged CPR, because
Yes.
we,
I'm trying to just get my. Am I heard?
Yes,
yeah,
ma'am.
you are.
Yes, ma'am.
Oh, yeah, yeah. Okay, okay, okay. I thought I'm muted. Hmm. Uh, Actually, in CPR, actually what happens is last is is our differential diagnosis. If we see anything like in deep sedation, convulsion is not something that is seen always, but and if we've given a muscle relaxant, even if it is convulsion, it is not manifested. So for us, it is a diagnosis of exclusion, as it were, unless we really see a lot of bizarre arrhythmias. So whenever it is last or whatever it is, for us, that the child has stopped breathing, if at all the child is spontaneous, that the rhythm has gone haywire, or that there is something going wrong on the ECG or bradycardia, we all have a same algorithm. Switch off the anesthetics, start the CPR. If we have not intubated, intubate a definite airway. We go to the latest CPR guidelines for children. If it is immediately after local anesthetics, yes, call for intralipid, but continue this. If we do not get intralipid in time, which might take some time, shouldn't actually, we do depend upon low dose of adrenaline as well, and the CPR continues because it's a very kind physiology. It's a narrow range physiology, but a kind physiology. If we continue our CPR properly, as Ethel has put it so well, we do get children back. So you have what we have to remember is how long is the effect of bupivacaine by itself going to last. I'm not saying intralipid is not important. It's the most pivotal aspect of managing last in children, but until then there is no way that we can skip any basic life support and then go to adrenaline as well. We can shock these rhythms, but I'm not too sure whether we will get a rhythm for a long time. And anyway, it is not going to work. So CPR definitely has to go on with 100% oxygen and with all the anesthetics off.
Thank you, ma'am. Neeta ma'am, any comments from your side?
A really nice presentation, and I think we have discussed often a theoretical question is also upon the mechanisms and theories of the lipid emulsion. How does it act? We've covered on those topics. My question would be, uh, how long after, if you're planning a regional anesthetic, is the chance of last possible? Because there are anecdotal reports of different time intervals reported. So, like, what is it? Is there a time defined till when we need to be watchful about the particular patient experiencing that.
Okay, Gauri, can you answer ma'am's question?
Yes, sir. Usually, it is recommended if at all we give a regional anesthetic technique, we have to keep the patient under observation for at least about 45 minutes to 1 hour, because there can be a delayed absorption of the local anesthetic as well from the tissues. If we have, put into a more vascular tissue, there can be a delayed presentation of local anesthetic systemic toxicity as well. So it is ideal to observe for at least 45 minutes to 1 hour, sir.
Another question obviously would be the preventive steps, which you have definitely covered in your slide. As in, what preventive steps would you take to prevent LAST probably? Yeah.
Yes. So we have to use always the lowest effective dose possible, even though we have calculate the maximum toxic, like allowable toxic dose. And when we calculate the dose, we have to be mindful that we are calculating on the basis of lean body weight and not the total body weight. And we have to use incremental injections. That is, we have to inject, say, about 3 to 5 ml, then wait for a circulation time that is about 15 to 30 seconds before the next injection, so that we are confident that we are not injecting into any vascular structures, and frequent aspiration between all the aliquot injections. So aspiration is not completely definitive of not an intravascular injection, so we have to be watchful each time we inject an aliquot. For next is use of a intravascular marker like epinephrine, so that we know if our drug is being deposited into an intravascular space whenever possible. Use adjuncts like ultrasound guidance, so that we stay away from the local anesthetic, away from the vascular tissues. So these are the uh, recommendations that have been put by ASRA as well, ma'am, to prevent the LAST.
Correct. So these you have said you will have to be prepared for saying this in the Viva. Is there evidence to state a PNS versus ultrasound makes a difference in the incidence of LAST? I'm talking about with regards to literature.
Actually, she has made a very nice point, a very confident answer, I must say. Tell me, you touched epinephrine. Tell me, what is the exact epinephrine dose that you expect to to show you signs?
Ma'am, about 10 to 15 mics of epinephrine, if we have injected intravascularly, that is, say, about, we usually give 5 mics per ml of epinephrine. If it is 10 to 15 mics, we get a increase in the systolic blood pressure by about 15 millimeters of mercury or more, and the heart rate also increases by 10 to 15 beats per minute or more.
Perfect. That's perfect in adults. In children, how would you do that?
Ma'am, children, the epinephrine dosage is around 0.5 mics per kg.
Wonderful. Okay.
So this also increases about 15 millimeters of mercury of pressure and about 15 beats per minute heart rate.
20 to 30 beats per minute heart rate. Okay. What would be that one sign in children that would definitely tell you after the epinephrine test dose that we are now dealing with something? Because tachycardia might get masked with the concomitant general anesthesia or deep sedation that is being given. Tell me that one specific sign.
With epinephrine, ma'am, you are saying?
Yes, yes. What with epinephrine?
Increase in the blood pressure is what I have read, ma'am. Like.
Okay. So always remember the most specific sign here is T wave amplitude increase. Tachycardia, yes. Blood pressure, yes. But if you see the increase in amplitude, be sure. Uh, be sure you're dealing with. It's a very, very specific sign. Yeah. Yes, that is how you will look at epinephrine. Tell me, if I pick up the local anesthetic, which is available in our anesthesia cards, which is 2% lignocaine adrenaline, how much should I aspirate to get the dose of 0.5 microgram per kilogram in a joint?
It is 5 mics per ml, ma'am. So about point.
Correct. Go ahead.
Yeah. So 0.1 ml per kg of the the drug.
Yes, yes.
So,
Yes. And you know something, something even more wonderful here. Suppose if you use lignocaine adrenaline in a dose of, say, 5 milligram per kilogram, which is a dose recommended for children, isn't it?
yeah.
You give almost 4 times this dose. So you get a lot of, although no literature really tells you this. But what happens is if you mix, say, bupivacaine or levobupivacaine or ropivacaine and 5 milligram per kilogram of lignocaine adrenaline, and say maybe 2 milligram per kilogram of levobupivacaine, which are the lower dosages of both the local anesthetics, that mixture gives you more than enough of adrenaline, almost 3 times of what actually will manifest as a test dose. So, so I guess that would be a good idea to use, especially in those blocks where vascular absorption is far more. Good. That's
Dr. Anshuman Mishra was there. Are you there, Anshuman?
Hello, sir.
Yeah.
Hello, ma'am. Vishal, ma'am.
Any
Actually, it's a
comments?
very good,
hello.
nice
Hello.
presentation. Yeah, ma'am. Actually, this is a very nice presentation, very descriptive, very detailed, and we all loved the presentation. And as Dr. Hetal had also asked, usually the commonest cause of last is where you least expect it, like the facial plane blocks, where the volume is more and we keep on giving a higher volume. But the presentation was very nice. It was a long presentation. It's definitely a boring presentation because it deals with the physiology part. But at the end, she covered everything up. It's a nice presentation, good presentation.
Just a
Thank you.
food for thought for all our students here. Remember what havoc is happening here with these drugs whose we know that the receptors are going to liberate it in some time. And remember what havoc will happen if we really use the liposomal bupivacaines. It's just a food for thought. Imagine. I mean, it is going to be very difficult and nobody's considering it, I feel. How would you, what antidote, how much of intralipid, if at all happens, what, for how long will we consider, I mean, how long will it take and what should be the ideal steps? And there are no guidelines to understand. I mean, we haven't just given a deep thought, I feel. So food for thought. We don't know the answers yet.
Yeah, definitely yes. And I would like to just be warn everyone, like, when we are using catheter techniques, multiple catheter techniques, the errors like wrong connections can also be a risk. We should be very careful in connecting. If you are relying on the pain nerves or or if it is not followed up properly, there can be wrong connections which can lead on to complications like last and other things. So whoever using continuous catheter techniques, and even there have been literature where there have been wound installation techniques, particularly in Sweden, where they've used elastomeric pumps. And one from Bombay, one of the pediatric patients, I think it has been reported that the elastomeric pump malfunctioned because of underfilling. It has got a lot of implications. I forgot madam's name. Dr. Dave's one paper is there. So malfunctioning and wrong connections are an important thing when, even if we think like low concentrations are given. See, so we should be very cautious about it. And the papers before 2000 have come up in Australia and Sweden, where they have used wound infiltration technique. So it's worth reading, and complications about that. So yes, it was a wonderful presentation. Thank you.
Any comments from any other fellows? Sangamitra, are you there?
Yes, sir, I'm there. There is no message in chat box also, sir. No questions there.
So shall we
So
go
she has
for
presented
quiz?
so nicely that everything wonderfully, and I think this will be a masterclass for all the fellows for LA and last, and
Yeah.
they
So
can
for those
revise
two
from the videos
classes,
only.
yeah, yeah. The USG spine,
So just
this,
wanted to sum up for the fellows that it is being overwhelming when we read LA and the last. But just remember, you whenever you are answering your questions, answer it point wise. Remember all the properties of the LA. Usually the questions come to compare to local anesthetic, either on table viva, on case, or on theory. Usually that is the uh, question that is being asked. So always remember to answer it stepwise, just like Gauri answered the last question, which ma'am was asking. And always remember, go stepwise, methodical, then you can score good marks. And just remember all the points.
Yeah.
Okay, ma'am.
Sure, sure. And remember, everything is not last. It can be
Yeah,
anaphylaxis also. It
yeah,
can be wrong
definitely.
dose going at the wrong place also. Such as,
Yeah,
you calculate something for spine and then it goes in epidural also.
true. And just wanted to add one more comment is that when you calculate the maximal allowable dose, what we practice is we practice 75% of the maximum allowable dose is allowed for your definitive block and keep the remaining 20% for a rescue block if required.
Ah, okay.
So that is how we practice, and we have a margin of 25% in our hand whenever we do a rescue block if required. So we use only 75% of the maximum allowable dose for any block that we do, and that includes the concentration and the volume multiplied.
Gaurav, we follow
Sorry.
50%. We follow
Oh,
50%. For example, if you are using, we have a simple equation for all our facial plane blocks and everything. We take
okay.
0.25%, 1 ml per kg. I mean, in an adult, we rarely go over and above 60 ml. And in children, though, we are very careful and caudal for
So
analgesia
I'm
purposes,
I'm talking
it will be
about the
less than that.
maximum volume that we use.
Correct.
That
No,
will
correct.
not
Yeah.
cross 75% anytime.
Yeah.
50% is good. We also don't go beyond 60 ml for an adult, but there are a lot of adults who come are 40 kgs.
Yeah.
And facial plane blocks, when you have to give bilateral, then the volume requirement is more.
I think better to have some such protocols, and so that it will mechanically go through the system wherever we are working, and not to cross.
Right.
And even the technicians also will be used to giving not more than that concentration. So that's a good practice.
Yes, sir. Yes. Sir. Thank you. Thank you, sir. Sangamitra ma'am, you can take over. Thank you.
yes, sir. I will continue with the quiz. Rest of the faculties, if they want, they can.
I believe this is the last class for this batch. Is it?
Yes, yes, sir. Yes, sir.
So
Last class.
so best wishes to
Last
all
is
the
the last
fellows.
class.
Yeah. So
Sir, just one input, sir. I don't know if she has added it. I just wanted to add that the Articaine is the local anesthetic, which is the safest anesthetic for any transplant patient. Usually, the transplant patients go and undergo a lot of dental procedures, and the question might come, which is the local anesthetic that is safest. So that is Articaine. I do not know if it is available in India,
So
but
we
I thought the fellows
revealed
should
one of
know
the
it.
quiz questions, sir.
Yeah, there will be a question for MDs, I think, dental chair anesthesia. In that, it will be coming. It is available in India, and most often it comes as I mean, anybody wants to add anything? Gauri, have you read about it? This is one comes as cartridges. That's a very confusing cartridge. I think it is more often used in dentistry. I mean, said to be the most safest. It's interesting to read dental chair anesthesia. I think pediatric most often. We used to have some exposure to this some time back, but it's interesting to know. Yeah.
So we have today two food for thoughts. I would like Dr. Naveen, fellow from Sancheti, to look for articles related to liposomal bupivacaine and last. And Harsha, if you get time, look for this dental chair anesthesia. And if you can share some articles in next 2 days, so that we all can read and ponder over it.
Yes, ma'am.
Okay?
Yes, ma'am.
Yeah.
Yes, ma'am.
Any other fellow who can add on, it's always welcome. I'm just allotting people so that somebody will be responsible to put it rather than missing it out again. Okay?
okay, thank you very much. Good night.
Good
Ma'am,
night,
hats
sir.
off And Hippe Pure to Sangamitra ma'am for a wonderful year. And all
Yes,
fellows should give a treat to her.
yes, very true,
Yes,
very true. Commendable job.
It's
it's
because
not an easy task.
Highly
Thank you.
appreciated. Highly appreciated.
thank you, ma'am.
Thank you,
But
ma'am. Good
I
night.
think
Thank you.
not a single fellow missed out this time. So thanks to all the fellows.
They are wonderful. All the best to all of you. And please remember, you're the ambassadors for AORA. So when you pass out, I am quite sure the subject is fascinating enough not to leave you.
True, true, very true,
And
ma'am.
stay connected. All of y'all, stay connected with AORA.
Yes, ma'am. Thank you, ma'am.
Thank you.
Thank you. Thank you. All the
Thank you,
best.
ma'am. Thank you,
Thank
sir.
you. All the
Best,
best, dear
Thank you. Good
ones.
night.
Thank you.
good night. Best wishes to all of you. Good night.
Yes.
Night,
Yes.
everybody. All the best to all.
So fellows, please stay. We'll go ahead with the quiz. Okay. Is my screen visible?
Yes, ma'am.
Okay. Nandini, can you join and conduct the quiz? I will just keep on moving the slides.
Yes, Sangamitra.
Yeah, hi Nandini.
Hi,
Welcome.
hi, hi. Hi. Thank you. And good evening, all.
Gauri, wonderful presentation, huh? I must say.
Thank you, ma'am. Thanks a lot.
Sangamitra, I have a doubt. You will keep moving it, right? I just
Yeah,
have
I will.
to
I am there.
read it out.
Yeah. Just channelize
Yeah,
and if you
okay.
want, let me move it. I will be there.
Yeah,
Don't.
yeah. Yeah, yeah. Okay.
I think most of you have joined. Shall I start the quiz? Or anybody is waiting to join?
Yes. So the first question is, which of the following is true regarding the esters and the amide type of LA? Option one, prilocaine is an amide type of LA. Amides are generally less toxic. Esters have a longer duration of action. Allergic reaction to esters are rare. The right answer is prilocaine is an amide type of LA. So PB is stopping the quiz now, followed by Gauri and Yogesh. So second question, which LA demonstrates the greatest degree of stereoselectivity in its action on sodium channels? Option A, you have lignocaine, B is mepivacaine, C is ropivacaine, and you have chlorprocaine. Correct answer is ropivacaine. Now Gauri is on top, followed by PB and Yogesh. Third question, which LA undergoes sulfocodone esterase mediated hydrolysis at the slowest rate, potentially increasing its toxicity? Procaine, benzocaine, tetracaine, and cocaine.
Okay, okay.
Answer is tetracaine.
Okay, okay. ठीक है सर, ठीक है.
Gauri is still on top, followed by PB, and now Varnika has joined the race. Fourth question, the addition of bicarbonates to LA solution can enhance onset by increasing which component? Lipophilicity, non-ionized form, protein binding, ionization. The answer is non-ionized form. It increases a non-ionized form of LA. Still Gauri is on top. She has a streak with 4 correct answers, followed by Varnika and PB. Why amide LAs are less likely to cause allergic compared to an ester LA? Option A is lack of interaction with GABA receptors. B is low lipid solubility. C is absence of para-aminobenzoic acid. And D, metabolism to inactive metabolite. And the answer is absence of para-aminobenzoic production. Gauri is still on top, but Vanika has a streak with 5 correct answers in the row. And third is PV. Sixth question, which LA enantiomer has been shown to have less potential for systemic toxicity? S enantiomer of bupivacaine, R enantiomer of ropivacaine, S enantiomer of lignocaine, and S enantiomer of prelocaine. The answer is S enantiomer of bupivacaine. Gauri is still on top, followed by Varnika and PB. Seventh question, in the treatment of LAST, why is the administration of calcium channel blocker is contraindicated? They exacerbate the CNS symptoms, they have myocardial depression, they interfere with lipid emulsification, they increase arrhythmias. They have myocardial depression. Gauri is still on top, continuing, followed by PB. Eighth question, the pillars of a last treatment consist of administration of propofol induction dose for contracting seizures, airway management and circulatory support, avoiding further alkalosis until initiation of lipid emulsification therapy, prompt administration of 2% lipid emulsion. The correct answer is airway management and circulatory support. Yes. Gauri is maintaining her position and not leaving for anybody, followed by PB. So the ninth question, which statement is true regarding the last? Inferior alveolar block, rare. Injection next to the vessels, poor area of pterygomandibular block. Last can even occur with topical dose of LA for awake intubation. Retrobulbar block, epidural spread causing brainstem anesthesia. In the last is for TAP due to higher serum albumin level of pregnant patients. The answer is last can even occur with topical use of LA for awake intubation. Yes, Gauri is on top, followed by PB and EK. Patient-related risk factors for the last are extreme muscle mass, having epilepsy and seizure as comorbidity, malnutrition, and site of injection. Patient-related risk factors. Extreme muscle mass, yes. So the winner is, third place goes to EK, second goes to PB, and first is Gauri.
Gauri.
Congratulations, guys.
Now PB and EK have to share their full name. Otherwise, I will keep sharing like that only. Okay. So PB is Purva. Prerna
PT
Bellari.
is Prerna Bellari.
Okay. And EK is E Kavya.
EK is E Kavya. E Kavya.
Okay. Congratulations, all the kids. It was a very well presentation. I really loved it. And I will share the recording in 2 or 3 hours so. Okay. And thank you. Thank you for such a wonderful presentation, Gauri. Thank you, Nandini.
Thank you, ma'am.
Thank
Thanks a
you,
lot for
Sangamitra. Thank
coordinating.
you so much, and all the very best to all the fellows.